Has Dr. Zini joined? Dr.
Yeah.
Zini, yeah, please start the meeting.
Hi. Good evening, everyone. So it gives me a great privilege to join today as the convener for the meeting for tonight. We are starting with part one of multi-fetal gestation. And today we have amongst us very eminent personalities, and we have Professor TLN Parveen with us, who shall be starting today's SFM monthly Ludhiana meeting. Which is now becoming a regular practice, and we are having some really great sessions under the able guidance of Dr. Naveen Pereira, who has led the Ludhiana SFM team very well in the last year. And thank you, sir, for all the organization and for conducting the talks and taking so much time and putting so much time and effort. He's very conscientious about everything is being done properly or not. He keeps calling me, he keeps checking over and over again, so then just to make sure that things run smoothly. So we really appreciate that, sir. So I will just like to share my screen, and I would like to first of all make the introduction of the panelists today. Just a second. Oh, where is it?
Dr. Zini, you can start off probably by introducing Sir TLN Praveen, sir, because he's a
that's what I'm doing. Yeah, I'm just got a CV up, sir. So just 1 second, please.
There's no need to read, man. You just tell something. It's okay. We'll start off.
Okay, sir.
Some people don't need any.
Yeah, actually, it doesn't need any introduction.
introduction.
Remember, we talked in the morning.
That's true. No, it's an honor, sir, for us to have you in our midst today, so that we've learned so much from you always. And now, can you see my screen now?
Absolutely, we can all see it.
Just 1 second, I'll just put it on slide share. Okay, hang on, sorry. Okay, a man who needs no introduction, Dr. TLN Praveen. He is MD and DMRD, who has been a professor of radiology, director at the Abhishek Institute of Imagology, and he's been practicing in fetal medicine for past 35 years, and has great passion in looking at the fetus and performing invasive procedures. And of course, he's been very, very active in teaching and training all students of his in whatever career level they come to him. He's been a publisher and reviewer for many, many journals. He has been the past vice president of the National IRA, past president of IFUMB, and he's currently the president of the Society of Fetal Medicine of India. Of course, he has received several awards, and he's received the Certificate of Excellence for First Coronary Angioplasty in the country, and has received several appreciation awards from Foxy, Dr. Ashok Mukherjee Gold Medal, the Indira Priyadarshini Award, and Lifetime Achievement Award by TSIRIA. I welcome you, sir. And today's sir's talk is going to be determining chorionicity in multiple gestation. Is it necessary?
Thank you, Ginny. And I think if you, Anja, thank you. Thank you very much for those nice words. And it's indeed a pleasure being with you all. With particularly the Ludhiana chapter, we have a different affinity towards all of you, because you work hard. You are putting SFM on a real run, so that every chapter is going to do the same way. And let me start off with these few words. I will share my screen. Today's talk is on multiple gestation, chorionicity. Is it essential? Okay. We all know that the incidence of multiple gestations have dramatically increased. This increase is basically because of assisted reproductive techniques that are being followed, as well as aging maternal population and late conceptions. We all know that these multiple gestations are high-risk pregnancies. They are high risk for both the fetus as well as the mother. And the morbidity is almost twice that of the singleton, and mortality is almost 6 to 8 times the singleton. The complications are such as the preterm birth, intrauterine growth restriction, and the anomalies occur at a higher frequency. And there are certain unique complications such as TTTS, TOPS, TRAP, and TAPS are known to be seen with these monochorionic twins. Now, what is the approach we have as far as the multiple gestations are concerned? It is the outline one where we first and foremost thing, of course, in the initial stages, we try to evaluate the presence of gestational sac or number of sacs are identified, as well as the viability is assessed, and then we date the pregnancy. Date the pregnancy similar to that of a first time, the singletons. And at the same time, this is the one which determines the gestational age. And then we try to determine the chorionicity and amnionicity, which is one of the most important things. And that is what we are going to focus today. And why is it really essential? That's what I'm going to take you through. And then labeling the twins as well as timing of examination, both as in a dichorionic as well as a monochorionic twins, frequency at which we have to evaluate them, and the content of each of these ultrasound examinations are to be defined. So keeping this in mind, we try to start off with the dating, where, as in the first trimester, whether it is a singleton or a multiple gestation, ideally we try to date the pregnancy based on the crown rump length. And the larger of the two crown rump lengths in a multiple gestation, I'll try to put it as twins quite often because it becomes much more easier to say. And in twins, the larger of the two CRLs is the one which is taken to ascertain the gestational age, ultrasound assigned gestational age. And if it is after 14 weeks, that is after 84 millimeters, it is the large HCL, head circumference, that is to be used. And in IVF conceptions, basically we go by the embryo age from the fertilization, or we take the date of oocyte retrieval. So these are the things that we need to consider as far as the dating is concerned. Now, what is this chorionicity? Why are we giving so much of importance? We need to understand a little bit about the chorionicity. Basically, when there is a fertilization, we get the 2-cell stage, then we get multiple cells, we call that as blastocyst, and then the embryo develops. Now, this is what is important. And whenever there is a multiple gestation, which is polyzygotic, that means it indicates that there are 2 separate eggs and 2 separate sperms which fertilize, and then they develop, which are called as the non-identical twins. Whereas in a monozygotic twin, we have a single oocyte or the egg and a single sperm, which divides to form identical twins. So this is what is the basic concept about the zygosity of these multiple gestations. Now, in the multiple gestations, the chorionicity, when we say chorionicity, we basically mean the number of placentas that are present. In a polyzygotic twin, the chorionicity depends on the number of zygotes. So that is one most important thing that we need to understand. Whereas in a monozygotic twins, the chorionicity depends on the time of division. So based on the division, the chorionicity develops. So for example, if the division takes place less than 4 days, then we tend to get what is called as the DCDA, that is the dichorionic diamniotic. If it is between 4 to 8 days, it is usually the MCDA, and between 8 to 13 days, it is the monochorionic monoamniotic twins, and if it is more than 13 days, we do get what is called as the conjoined twin. So this is how the division of this fertilized blastocyst is the one which is going to divide, and this division, depending on the time of division, the chorionicity develops. So what does that mean? In the sense, if you have a dizygotic twin, in that 100% of them are dichorionic. That is, they may have 2 placentas which are separate from each other, or they may have a single placenta which is actually a fused placenta. That means there are 2 placentas which are fused together, but then still there are 2 placentas. That is the reason why you call it as a dichorionic diamniotic twin. Whereas in a monozygotic twin, we know that it all depends on the time of division. So if the division takes place less than 4 days, then 75% of the times it happens that way. And in that situation, we get what is called as the dichorionic twin. Whereas in almost 25% of the times, there will be either a division at between 4 to 8 days when it becomes the monochorionic diamniotic. Here it is the shared placenta. Even though here also we get only single placenta, but it is a shared placenta. But then you have an intertwin membrane in between the two twins. If the division takes place after 8 to 13 days, then it develops what is called as the monotwin or the monochorionic monoamniotic twin, where you have a single placenta, there is no intertwin membrane. So this is how the basic concept that we need to understand while dealing with these multiple gestations. Now, how to determine this chorionicity? Then the first important thing which we need to realize is that the chorionicity is best established in the first trimester of pregnancy. That is, when you take a gestational age with less than 10 weeks of gestation, it is nothing but the number of gestational sacs are equivalent to number of chorions, that is the number of placentas. So each gestational sac indicates a single chorion. In the same way, you can also consider the number of yolk sacs as the number of amnions. Even though the statement is not appropriate, the reason being that unless you demonstrate an amnion, you cannot ascertain the amnionicity of a pregnancy. But then at less than 8 weeks of gestation, it is extremely difficult to identify the intertwin membrane. And that is the reason why we usually depend upon the number of yolk sacs rather than identifying the intertwin membrane. But if it is after 10 weeks, quite often can demonstrate the intertwin membrane, which ascertains the amnion. Now, coming to late gestation, that is after 10 weeks of gestation, 10 weeks, in that situation, we try to identify the number of placentas. If you have a fused placenta, that can be identified by identifying what is called as the lambda sign or the twin peak sign, or when you have a single placenta, which is a shared placenta, in that situation, we get what is called the T sign, and the intertwin membrane thickness also tells us about the possibility of the chorionicity, but then it is not really an aspect which we can completely depend upon. And then we have the fetal gender, which anyway we are not going to make use of in identifying the chorionicity. Now, there are umpteen number of papers that have been published stating that the first trimester ultrasound determination of chorionicity in twins, which is supposed to be highly sensitive and specific. The sensitivity is in the range of 100% and the specificity is almost about 99.8. So obviously, we all need to understand that the ascertaining the chorionicity of the multiple gestation is best done in the first trimester. That is one most important message that I would like to convey. So for example, in this, we know that there are 3 gestational sacs, so it has to be a multichorionic twin. So this is how we are trying to identify the chorionicity. Now, as I said, the number of yolk sacs can be considered as the amnionicity. For example, here you have a single gestational sac. Obviously, it means that it's a monochorionic twin, but at the same time, you do find 2 yolk sacs and the intertwin membrane very clearly identified. So it has to be an MCDA. Whereas here, you find only 1 yolk sac, but you can nicely demonstrate the intertwin membrane. So these are basically, when you do a transvaginal examination, this is how you can identify. But when you do a transabdominal examination, quite often you do see only the yolk sacs, but the intertwin membrane becomes very difficult to identify. Similarly, you may find 2 embryos as well as 2 yolk sacs, but the intertwin membrane is not identified. So identification of amnion is important, but it is possible only after 8 weeks of gestation, particularly when you do a transvaginal examination. Since up till then, presence of 2 yolk sacs without demonstration of amnion has to be considered as a mono twin or a monoamniotic monochorionic twin. So this is one important concept as far as the amnionicity is concerned. So keeping this in mind, let us move on to the chorionicity, which is what we are really worried about and we are really interested in. That is the number of placentas. As we know, whenever you have 2 separate placentas, you know that you are dealing with a DCDA twin where there is no fusion of the. Whenever there is a single placenta with and you find what is called as the twin peak sign or a lambda sign, which is nothing but the trophoblastic invasion into the intertwin membrane, resulting in a peak-like structure, which is actually called as the twin peak sign. And this twin peak sign is the one which indicates that it is a fused placenta, but not a shared placenta. So when you have a twin gestation, when you have a single placenta, what you need to look for is presence or absence of the twin peak sign or the presence or absence of the T sign. whenever you find this sort of a twin peak sign, it obviously indicates that it is a it is a fused placenta, but not a shared placenta. Whereas if you, for example, you can see it here, where you find that there is a nice twin gestation, and you can see a beautiful twin peak sign demonstrated. This is a static image of the same case. Now, whereas here you find a single placenta, but then what you find is that there is a thin intertwin membrane which is being inserted directly into the placental tissue, as you can see here, and this is the classical T sign, which indicates that there is no intertwin or the trophoblastic invasion, which rules out the possibility of a fused placenta, and it indicates that there is a single placenta which is actually a shared placenta. So this is what is the most important concept that we need to take home as far as the shared and fused placentas are concerned. Now, there is another way by which you can try to identify the chorionicity, particularly by taking the thickness of the intertwin membrane. If the thickness of the intertwin membrane is more than 2 millimeters, then or about 4 millimeters, then you know that there are 4 layers, that is amnion, chorion, chorion, and amnion, which always indicates that there is a DCDA. If there is a thin membrane, which is about 2 millimeters or less than 2 millimeters, then it is usually the MCDA. For example, here you can find that this is a nice twin peak sign, wherein you can have a thick intertwin membrane, whereas here you find that there is a thin intertwin membrane which is actually inserting as a T insertion. So these are the two things that we need. So we base on to differentiate between a shared placenta and a fused placenta, we take into consideration twin peak sign, T sign, as well as the thickness of the intertwin membrane. But we don't really depend upon the thickness of the intertwin membrane, because the false identification of a thick membrane is always a possibility as far as the tangent of the ultrasound is concerned. So in these situations, we depend more on the lambda sign as well as the T sign. So that is how we are going to identify the choriones. Here in this one, of course, there is no intertwin membrane which is dividing the thing. So it has to be a monoamniotic, and all monoamniotics have to be monochorionic, right? Now, if the division takes place after 13 days, then in this monozygotic twins, there is always a possibility of a conjoined twin, which could be a thoracophagous, as you can see, a single heart and 2 fetal body, thoraces, or it can be a thoracoomphalophagous, where there is a fusion between the thorax as well as the fetal abdomen. So these are the things that we have to keep in mind. Now, in order to understand the implications of chorionicity, it is very easy to understand by taking what is called as the apartment analogy, which is just to make things much more clear to us and much more easier for us to understand. If you and your friend are staying in 2 separate apartments, which have 2 separate bedrooms and 2 separate kitchens, there is no possibility of any rivalry or any fight. Whereas if you have an apartment, you are staying in a single apartment with 2 bedrooms, but a single kitchen, there is always a possibility that there can be a friction. Whereas if you stay in an apartment where there is a single bedroom with 2 beds and a single kitchen, in that situation, you are bound to have some amount of friction. So this is one thing which will, so if you have 2 separate placentas, then there is no problem. Whereas when you have one placenta which is actually shared, then there is a problem. Or when you have a placenta which without any separation between the 2, then there is always a possibility of a friction. So this is what is important to understand as far as the chorionicity is concerned. So basically, how are we going to go about? If it is less than 10 weeks, we depend upon the number of gestational sacs. And if there is 2 gestational sacs, we call it as a DCDA. If it is 1 gestational sac, we call it as MC. If it is more than 10 weeks, you have to count the number of placentas. At the same time, check the gender. At the same time, check for the lambda sign or the T sign, or check the thickness of the intertwin membrane. In the 3rd trimester, it becomes very, very difficult. If there are 2 placentas, there is no problem. But if there is a 1 placenta, then it becomes very difficult in the 3rd trimester. Another statement that has been published is that if you get a patient in the 3rd trimester where you are really not able to demonstrate 2 separate placentas or the lambda sign or the thickness of the intertwin membrane, it is better to construe that as a MCDA twin rather than anything else. So this is how we are going to go about as far as the chorionicity is concerned. Now, labeling the twins is also an extremely important thing, and it is basically based on the location, that is based on the site, whether they are to the right of the membrane or to the left of the intertwin membrane, whether they are above or below the intertwin membrane. Not only that, it can be based on the insertion of the card relative to the placental edge as well as the membrane insertion. So these are the factors which we take into consideration. But if you are working in an institute where you get the patients referred by your own clinician in the institute, then you can always have an idea, understanding between the clinician and yourself, saying that all right-sided twins are called as twin A, all left-sided twins are called as twin B. But for people like us who are doing an independent practice, it becomes very difficult to convey this. So it is better to take into consideration the location of the fetus based on the insertion of the card or the intertwin membrane. Now, whenever we have a discardant twin, the potential recipient twin is always considered as a twin A. So this is one important thing, that internationally it has been accepted that the potential recipient twin is always considered as a twin A. Now, labeling in MOMO is useless because they keep moving and there is no demarcation between the two. Now, coming to the perinatal switch, this is one thing which we all need to understand, particularly the colleagues, our colleagues who are obstetricians who manage these patients, particularly when they deliver by cesarean section. There is always a possibility of what is called as the perinatal switch phenomena. In this, it's an extremely important because particularly when we have structurally discardant twins, and this structural abnormality is not obviously evident externally. In that situation, it becomes very difficult. The only advice that we need to give is that before the delivery or before the cesarean section, it's better to scan the fetuses, and postnatally also, both the fetuses have to be scanned. Because suppose, for example, you have a twin A, which is a diaphragmatic hernia, and twin B is a normal fetus, and there is a switch, and the twin B becomes the twin A, and twin A becomes twin B. In that situation, it becomes very difficult. So it's always better to do before the LSCS and after LSCS evaluation of these fetuses. That is what is called as the. Now, coming to the timing, frequency, and content of USG examination, the dichorionic twins are same as that of the singletons, except that in the mid trimester, that is the anomaly scan, we not only see detailed anomaly, biometry, as well as the amniotic fluid and cervical length. As we progress to 24 to 26, as well as the 36 to 33, we do fetal Dopplers also. Whereas in a monochorionic twin, the frequency at which you are going to evaluate these fetuses are much more. And not only that, we are going to start depending on the Dopplers in evaluating these twins. Particularly, it's from 16 weeks onwards, you start evaluating the fetal growth, because we all know that the monochorionic twins are the ones which have certain unique complications, such as the selective fetal growth restriction and certain unbalanced sharing of the placenta, resulting in certain hemodynamic variations, which can be identified by taking the ductus venosus as well as the umbilical artery PI. So similarly, at 20 weeks, and then we follow it on to the delivery. So this is how you are going to now. Screening of aneuploidies in a twin gestation is very difficult, is complicated. In multiple pregnancies, there is higher risk of aneuploidies than the singletons, we all know. But then there is a statement which we need to remember very well, is that prevalence of Down syndrome in multiple gestation is much less than the theoretical prediction, definitely not double the singleton. See, previously we used to think that it is usually the double the singletons, but then that is a theoretical proposition, but usually in practice, it is not as high as that. The risk assessment of twins, as I said, is complicated. It is the zygosity rather than the chorionicity which determines the degree of risk. In monozygotic pregnancies, either both the twins are affected or non-affected, whereas in a dizygotic twins, the risk is more or less independent. Now, when we take the screening for aneuploidy, the risk of abnormalities is, in an MCDA, the risk is calculated per pregnancy based on the average risk of both the fetuses, because these twins share the same karyotype. So NT measurements is taken, averaged, and then they calculate the single risk estimate. And that is the reason why we call it as risk per pregnancy as far as the MCDA is concerned. Whereas the DCDA is concerned, we call it as risk per fetus. That is, the fetus specific risk is calculated. So these are the things that we need to keep in mind. And remember that quite often what we depend upon is the NT, and the NT distribution. It does not differ between a twin and a singleton. But the chorionicity can affect the estimated risk of Down syndrome. And these are the things that we need to keep in mind. But particularly, we consider the maternal age as well as the NT is an accepted method, whereas the combined screening can also be used, but then it only decreases the false predictive rate. And and in cases of a vanishing twin, the measurable fetal node, NT, and maternal age are factors which are considered in screening for aneuploidies. And NT alone, detection rate is almost 87%. And remember, between the MCDA and the DCDA, the NT is almost 1.5 times greater in MCDA than the DCDA. So this is one thing which we have to always keep in mind while evaluating or screening these things. Now, there has been a lot of talk going on as far as the cell-free DNA is concerned in the analysis of cell-free DNA in multiple gestation. This has all started from 2013. The important consideration is that the two fetuses may contribute different amounts of cell-free DNA into the maternal circulation. Now, the cell-free DNA should not be used in pregnancies with vanishing or a demised fetus, but then it can be used only after 6 weeks after the demise or after the vanishing has occurred. Now, the repetition quite often is quite high because of the low concentration of cell-free DNA in the maternal circulation. Quite often, the cell-free DNA analysis of multiple pregnancies is done by what is called as the SNPs technique, not the sequencing technique. It is the SNPs technique that which is used. Not only that, there is one thing which is called as the FORTE. That is what is called as fetal fraction optimized risk for trisomy evaluation algorithm, which really helps in estimating the fetal fraction contributed by each twin. And the cell-free DNA is not useful in sex chromosome abnormalities. And in twin pregnancies, lower fetal fraction is the one which is used, not the total fetal fraction in assessment of cell-free DNA. These are certain facts that we need to understand. So here also, the chorionicity is again an extremely important factor which we need to keep in mind. Now, coming to the importance of chorionicity as far as complications are concerned, you can see that we have, as we're taking the complications into consideration like miscarriages, postnatal mortality, preterm delivery, selective fetal growth restriction, major structural abnormalities, all of them are very high as far as the MCDA twin is concerned. So this is basically because of unequal sharing or velamentous cord insertion in which there is an unbalanced blood flow, resulting in all these abnormalities, which are very, very unique to monochorionic type diamniotic twins. Now, coming to the structural abnormality, risk of fetal anomalies is greater in multiple gestation than the singleton. You can again use the chorionicity take the chorionicity into consideration because in a dichorionic twin, the incidence is 1 in 25, whereas in a monochorionic diamniotic twins, it is 1 in 15, whereas in a momo twin, it is 1 in 6. So definitely it indicates that the risk of a structural abnormality is very high as far as the MCDA and MOMO are concerned. Major structural abnormalities should be as early as possible, identified in the first trimester, but then reconfirmed at 18 to 20 weeks, and the cardiac evaluation has to be performed. Now, to summarize and conclude my talk, there are certain take-home messages which I wanted to give you. One is the incidence of multiple gestations, as we all know, are increasing. It is essential to evaluate them based on the guidelines. Most important aspect is to establish the chorionicity and amnionicity in the first trimester. This is an extremely there is nothing much that we can stress more, because whenever you are evaluating a multiple gestation, if you are not going to mention the chorionicity, it has very little relevance in our clinical practice or management of these fetuses. It is important to date the pregnancy and label them. Unique abnormalities of single sharing placenta needs to be meticulously evaluated. Screening aneuploidy is a complex method and requires clear understanding regarding its applications as well as the limitations. Invasive testing in multiple gestation should be properly planned. And a screening for structural abnormality should be attempted in the first trimester, but should be confirmed once again in the second trimester too. Hence, I conclude my talk saying once again, ascertaining chorionicity is extremely essential. Thank you very, very much.
Thank you so much, sir, for your very, very valuable talk. And I think you have very clearly emphasized the role of determining chorionicity, which has so much implication in the management of twin or multi-fetal gestation. Let me see if there's any questions in the chat box. Now there is one question. What is the role of EFTS in twins? From Dr. Tulika Joshi.
Pardon me, no, I couldn't get you, sorry.
What is the what is the role of EFTS in twins?
What does EFTS mean?
Yeah, even I'm not sure. Can you elaborate that, Dr. Tulika? Okay, we'll come back to that question later because we have limited time. So thank you so much, sir. And I will now call on to the next presenter. It is Dr. Rajiv Garg. I just want to share my screen. Right. So Dr. Rajiv Garg has very kindly agreed to present a case for us. He is a senior consultant radiologist working at the Redneck Diagnostics, Ludhiana, and his area of course of special interest is fetal ultrasound, fetal echo, and 3D and 4D ultrasounds. He has been a regular speaker at a lot of regional forums, and he has professional affiliations. At present, he's the treasurer of the SFM Ludhiana chapter. He's also been the ex-general secretary at IRIA Punjab and Central Council members. We welcome you, sir, and please go ahead with your talk.
Thank you, Dr. Jinni, for nice. Okay, thank you, Dr. Jinni, for nice introduction, and thank you very much, sir, Dr. Praveen. It was a very nice talk, and we are really enlightened by your this wisdom. So today's case presentation is on the dichronic diamniotic twin pregnancy, which was discordant for the NN cavity. Regarding brief case summary, she was 28 years old, primary gravida, and by LMP she was 20 weeks and 6 days of gestation. The patient came for the routine first trimester NT-NB scan, and it was a spontaneous conception, no history of IVF, and there was no history of any bleeding per vaginum or any leaking. We did the routine first trimester ultrasound, and as sir has already very nicely shown the chronicity, but
Dr. Rajiv, sorry to interrupt. Will you be sharing a screen for the case presentation? Or shall I share the case? We are not seeing the case.
No, I have already started screen sharing. Is it not visible?
No, we cannot see your screen, Dr. Rajiv. You could probably unshare and share again. Yeah.
Is it visible now?
Yeah, we can see it now.
Yes, sir. Thank you.
Okay. So this is a case presentation on the dichronic diamniotic twin pregnancy, which was discordant for the NN cavity. Regarding brief case summary, she was 28 years old, primary gravida, and by LMP, the patient was 12 weeks, 6 days gestation, and she came for the first trimester routine NT-NB scan, and it was a spontaneous conception, no IVF, and there was no history of bleeding per vaginum or any leaking. So we did the routine first trimester ultrasound, and we can see the chronicity. We can clearly see this lambda sign, chorion dipping into the two membranes and thick membrane separating the fetuses. And in the fetus A, we were unable to see the bony calvarium. This is the sagittal image, and the absence of the bony calvarium and the brain tissue above the level of the orbits. This is relatively a face image we can appreciate. And the second fetus was showing the normal bony calvarium with the brain tissue, choroid plexus, we can clearly see. So in this section, this coronal image, absence of the bony calvarium and the brain tissue above the level of the orbits. And in the sagittal image, we are unable to see the bony calvarium. And the second fetus, which was normal, showing normal bony calvarium and the brain tissue, and even NT-NB was also normal for the fetus. And both the fetuses were not having any other anomaly. So the diagnosis of the anencephaly in the one fetus was made, and patient was consulted accordingly then. To summarize our ultrasound finding, it was live DCTA twin pregnancy. There was discrepancy in the CRL of both the fetuses. Fetus with the anencephaly was shorter in length, CRL 56 mm, while the second normal fetus was showing CRL 64 mm. And there was non-visualization of the calvarium in the twin A with the absence of the cranial structures above the level of the orbits. And the second fetus was showing normal calvarium in the brain and no other anomaly in both the fetuses. So the management, patient was advised genetic testing and the selective fetal reduction of the anomalous fetus, and patient agreed for that, and patient opted for the selective fetal reduction for the anomalous fetus. And after the procedure, intracardiac potassium chloride was given, and no major complication after procedure occurred, and patient continued the pregnancy and delivered a healthy baby at the 34 weeks of gestation. So what is anencephaly? Anencephaly is a neural tube defect in which there is a absence of the bony calvarium and the cranial structures above the level of the orbits. Its incidence is about 1:1000 live births. Most of the cases can be identified by the ultrasound at 11 to 14 weeks of gestation. It comes under the neural tube defects. So what are the causes of neural tube defects broadly? It has multifactorial inheritance, or there can be some complex Mendelian syndromes, genetic syndromes, or some may be associated with the chromosomal abnormalities, especially trisomy 13, 18, triploides, or there can be some unbalanced translocations. Teratogens have very important role. Anticonvulsants, anti-epileptic drugs are very cost effective for these neural tube defects. And in twin pregnancy also, there is a relatively high incidence, as Dr. Praveen has already told us. And maternal causes, diabetes, obesity are also common causes. And syndrome of craniofacial and limb defects, etc., can be there. Now, the main point is, what are the complications of discordant fetal anencephaly? Increase in the amniotic fluid volume, that is polyhydramnios, is the main complication of this discordant anomaly. And polyhydramnios leads to preterm delivery. And there can be discordant growth of the fetuses also. And sometimes there can be intrauterine death of the anomalous fetus also. So what should be the management? If the pregnancy is dichronic twin pregnancy, continuation of the pregnancy without intervention can be done. Expectant management can be advised. But we have to follow up with the serial ultrasound examination for the development of the polyhydramnios. It is the main complication, and increase in the severe polyhydramnios can lead to preterm birth also. So if the polyhydramnios develops, we have to do the amnio drainage. Or we can do the selective feticide of the abnormal fetus. There is a literature, data in the literature, whether it should be done 16 weeks or after 16 weeks. So it should be done before 16 weeks because there is a relatively high incidence of miscarriage after the 16 weeks of gestation. If the pregnancy is monochronic twins, conventional selective feticide with potassium chloride is not possible due to high risk of the demise of the normal co-twin. So expectant management can be offered, or selective feticide should be done by cord occlusion or the cord coagulation. The facilities for cord coagulation are not easily available everywhere. Finally, to conclude, discordant anencephaly can be easily diagnosed by ultrasound between 11 to 14 weeks of gestation, and selective reduction in the dichronic pregnancy should be preferred to reduce the risk of development of polyhydramnios and the preterm birth in the fetuses. And if expectant management is opted by the patient, we should do the close follow-up by the serial ultrasound examination. And whenever we detect the polyhydramnios, amnio drainage can be done. If the monochronic pregnancy is there, conventional selective feticide is not possible. Either we have to do the expectant management or the selective feticide by the cord occlusion should be done. that's all about this discordant anomalous anencephaly. Thank you so much.
Yes,
Go to Dr. Jenny. Yeah.
thank you so much, sir. If you just stop sharing your
Sure.
screen, I welcome any questions. It was an interesting case where we had a different anomaly in one twin, and then of course, what do you do in these situations just to have a good outcome of the second pregnancy? So with that, I would like to, keeping the time in mind, I'd like to now call upon the next case presentation, which is by Dr. Kavita Agarwal. Dr. Kavita Agarwal is a consultant radiologist working at Spectrum Center, Scan and Research Center, Ludhiana. She has got a special interest, of course, in fetal medicine, gynecological imaging, as well as mammography. And she is leading the Raksha Abhiyan Ludhiana chapter IRIA. And she's presenter and moderator for the academic sessions at state level IRIA conferences. Welcome, Dr. Kavita, and please go ahead with your case presentation.
Yeah, thank you so much.
Have to close this.
Yeah, a very good evening, everyone. My case, a 34-year-old primary gravida who conceived with ovulation induction, was referred to our clinic. An ultrasound examination performed at an outside radiology clinic at 16 weeks gestation demonstrated a monochorionic diamniotic twin pregnancy. And one of the twins was reported to have a morphological abnormality. When we scanned the patient at 18 weeks, monochorionic diamniotic pregnancy was confirmed. There was a single placenta with a very thin separating membrane, and the placenta was of normal appearance. So we have a single large posterior placenta, and there was a very thin separating membrane. I don't think that I need to stress that the chorionicity was already confirmed in first trimester. Fetus 1 showed normal 18 weeks growth. The fetus had normal morphology. There was polyhydroamnios. There was no cardiomegaly and no hydrops. Whereas the other fetus had an incompletely formed skeleton with a deformed head and thorax. There were no upper limbs. The abdomen was well formed, but with poor organ differentiation. There was presence of fetal ascites. There were 2 well-developed lower limbs with bilateral club feet, and reflexive movement of the lower limbs was seen. There was marked subcutaneous edema present in this fetus. So let's take a look at this fetus. This is a long section of the fetus. We see an incompletely formed cranial end. There is a partially formed skeletal in the region of spine, and there is, this is the caudal end with well-developed lower limbs. This is a cross-section of the fetal head, where the fetal head is, there's a deformed fetal head, no skull bones. Disorganized amorphous tissue is seen at the cephalic end. This is the cross-section of the fetal abdomen, which shows that there is a heterogeneous ecotexture, and we don't see any discernible internal organ in the region of fetal abdomen. There was presence of fetal ascites, and we can see extensive subcutaneous edema in the region of fetal abdomen. This is a well-developed femur, and there was presence of bilateral club feet. This is just a video which shows the cross-section from head to the lower limbs. I'll just play this for you. So in this, we have no skull bones, amorphous tissue in the region of head. This is the thorax, ill-formed organs in the region of abdomen, lower limbs, and bilateral club feet. When we put the Doppler, there was no heart rate in this patient. There were no cardiac pulsations, no color flow seen in the region of heart. So in fact, when this patient was referred, this patient was reported somewhere as anencephaly with IOD in one fetus, and the other fetus was reported as normal. So after looking at this, the scanning of the first fetus was done, which I had already seen that it was normal, but I wanted to rescan the fetus one. We saw normal head, normal spine, normal intracranial structures, normal cardiac views, normal facial profile with a well-developed NB, normal fetal bladder, a 3-vessel cord, good femur, normal fundal bubble, good extremities, but there was presence of polyhydramnios in this patient. When we scanned the umbilical artery, which showed normal flow in this fetus, and after this, when we put the color Doppler in the umbilical artery of the other fetus, which had no cardiac pulsation and which was actually the deformed fetus, we saw that there was flow in the umbilical artery in this patient and in this fetus, and the fetus, there was 2-vessel cord. And this, for my convenience, I've just reversed the flow to get the graph on the top. But if we see carefully, there is reversal of flow in the umbilical artery. The flow is in red, and there is just a single umbilical artery present in this case. We'll just see this. So it's a 2-vessel cord with a single umbilical artery in the fetus, which is deformed. So after this, after confirming presence of 2-vessel cord in this deformed fetus, but absent cardiac pulsation, I went and looked at the placenta. And we could see large anastomotic channels on the surface of placenta. So diagnosis of trap sequence was made with one viable pump twin and the other non-viable acardiac twin, which was actually acardias acephalus. So in trap sequence, just summarizing, it's a monochorionic twin pregnancy. The fetus 1, the pump twin, had normal biometry, normal morphology. There was presence of polyhydramnios, but there was no hydrops in this fetus. Fetus 2 was an acardiac twin, no development of heart. It was distorted, underdeveloped anatomy. Hydrops was present in this case. There was single umbilical artery with flow towards the fetus. That is the reversal of flow. There was single posterior placenta, large anastomosis on the superficial aspect of placenta between the pump twin and the acardiac twin. Cord insertion were seen. This is just a pictorial representation of the case in which we have a single placenta, one well-developed normal fetus, the other fetus with no development of the cranial end and poorly formed caudal end, but there is a flow in the umbilical artery in this patient, in this fetus, sorry. So just a quick view of the trap sequence, what happens. The incidence is about 0.3 to 1% of monozygotic twin pregnancies and 1 in 35,000 of total pregnancies. In this etiology is lack of well-formed heart in one of the twins, which is the acardiac twin. But the abnormal placental arterial to arterial anastomosis is the flow which supplies the abnormal twin. So the acardiac twin survives through these anastomosis. It uses blood, which has poor oxygen coming from normal twin, flows reversely in the arteries of the acardiac fetus. So the tissues of this fetus are thus poorly developed and atrophic because it is getting deoxygenated blood. And the atrophy is higher in the cranial parts because most of the caudal part is using the blood predominantly. There is association of single umbilical artery in acardiac twin in 66%, which was seen in this case. Chromosomal anomalies in acardiac twins are seen in 33%. So, and the complications of the twins in trap sequence, pump twin is at risk of cardiac failure, cerebral ischemia, sequelae, preterm birth, fetal demise in utero, all because of volume overload. And the risk of adverse outcomes in the pump twin is closely related to its size ratio to the acardiac twin. In this case, because of overt large size of the acardiac twin, that was not done. And the patient obviously decided to get the pregnancy terminated. As the acardiac twin is non-viable, the majority of the efforts in management are focused on maintaining the viability of the donor twin. And the perinatal mortality for the pump twin can be as high as 50%. There are various treatment modalities, but I think we have expert panelists today who can put light on this, but I'll just enumerate to complete the list. Is endoscopic laser coagulation or radiofrequency ablation, because the surgical destruction of the intertwin anastomosis is the purpose, or surgical or fetoscopic ligation of the acardic twin, or selective delivery of the acardic twin. Thank you.
Thank you, Dr. Kavita. That is a good identification of a rare abnormality. And yes, certainly, if we will see if the panelists want to go ahead and discuss how we can ablate or we can manage this pregnancy. Any views on that, Dr. Chanchal? I know I've just seen you on this one. Yeah, but we'll wait you to just put your audio device. So, okay, so this is when we say, you know, we have an acardic twin and you have a normal twin. So what are the options of, you know, with the second twin, the acardic twin, what do you want to do with that? What options of management do we have? We can't hear you. Can you unmute yourself? I think you have unmuted yourself, haven't you? You have, but we can't hear you. Yeah, that's better.
You have a question on this ND panel?
Oh, no, this is just on the trap case that Dr. Kavita just presented.
Right. So in trap, can you please repeat the question?
The question is, if you have in the trap, what are the managements of the second twin, you know, the one with the acardic, whether it's infra, whether it's laser or whether it's RFA, what would you prefer to, you know, for the...
I think Chanchal is talking, but then she's muted or...
No, she's, we can listen,
Yeah.
but it's very, the volume is very low.
Is it? Hey, just give me a minute. I'll try to.
No worries, no worries.
Can you hear me now? No.
Yeah, we can hear you better. It's better.
Are you able to hear me better now?
No.
Is it better?
No,
Yeah,
no,
yeah, definitely, definitely.
This is better. I think my earphones. So regarding trap, the consensus is that it should be reduced. It is.
Yeah.
The process is better. Earlier, we used to think that you do an intervention only when the pump twin is becoming hydropic or it is the trap is becoming larger. But the current consensus is it should be reduced. The technique whichever technique the operator is comfortable with. These, for example, in the either laser, because there's only a single artery that needs to be ablated here. RFA is technically more easier. However, RFA, because the caliber is a little thicker, so you would want to use an RFA only after 14 weeks in the second trimester. Nowadays we are increasingly diagnosing these trap pregnancies in the first trimester. So then currently the TRAPPIST trial is now, I think it has completed recruitment and we'll have the results soon. The issue is whether to reduce it at 12 weeks or later at 16 weeks. At 12 weeks, an interstitial laser is an easier procedure. It's more technically feasible. And after 16 weeks, one can use the RFA. But it depends on the comfort of the operator also. But at 12 weeks, doing RFA is difficult because the caliber of the RFA is it's 17 French needle. So it's easier to do it using an interstitial laser.
Thank you, Dr. Chanchal. Thank you, Dr.
Can I add
Kavita.
something here, Dr. Singh?
Yeah.
Since ma'am has said that it is becoming more popular treating it at 12 weeks. So what I've seen, another case I had seen last week was that the patient was reported as vanishing twin.
Mhm.
So as I mean, just that point I want to stress that when we as ultrasound report vanishing twin, we must make it a regular habit to just insufflate the umbilical artery. It is very important and it really helps the patient.
Yeah, that's a very important
vanishing or
point.
demised.
I've seen his report. She's absolutely right, because sometimes when they're seeing them in early pregnancy, and if the monochronicity doesn't really ring a bell, so sometimes we see a report of twins and with a vanishing fetus. So I think she's made a very valid point that if it is a monochorionic twin and with a fetal bit where you can't see a heartbeat, I think it makes sense to do a TVS and get better imaging and ensure that it's not a trap.
Another thing I want to ask, that before treating, do we consider it mandatory to do karyotype of the pump fetus?
No. If there are no markers for aneuploidy, it's
Okay.
not considered mandatory.
Right,
Yeah,
right. Because
association.
the literature says that there is increased risk of anomalies even in the pump fetus.
So if
I may be wrong, but I think it's about 8 to 10%.
But that literature mostly comes from prior to the first trimester screening. Here, when you are screening, when you have a nasal bone, and see, before any reduction, you do tell the parents that I've done an aneuploidy screening. The results are 90% detection rate. If you want something better, we can do an invasive and then reduce it, because this is what is available within 24 hours. And the QFPCR also comes within 24 hours. So that is the discussion same. It's not mandatory that if you're seeing a trap and if the other fetus looks normal, there are no markers, then you can have the same discussion.
Right.
If you want, you can do a CVS and at the same time.
Right. Thank you.
Thank you, Dr. Chanchal. We'll just have you back in a minute. Vishal, can we just have the trade partner video and then we'll go on to the panel discussion. Vishal, are you there? Okay. Thank you, Vishal. We'll move on to the panel discussion. I would now, first of all, like to welcome my panelists for the day. There are a lot of questions in the chat box, and I will now request Dr. Bimal Sahni to please take these later in the audience interaction session. So let me introduce the panelists for today's panel discussion. The first panelist is Dr. Bimal Sahni. He's director at Sonoscan Center, Aurangabad, and he's the president-elect of Society of Fetal Medicine, and he's also the academic coordinator for Scholar MD Fetal Medicine Training Program. And he's had several publications to his credit, and he's presented at various national and international conferences. Of course, his areas of interest are fetal growth Doppler and fetal echo. Dr. Chanchal, who we just heard, is a great friend, and she has her qualifications in MBBS, MD, and fellowship in fetal maternal medicine from Singapore, and she's a member of the FMF Foundation UK. She's the lead consultant fetal medicine at Rainbow Children's Hospital, New Delhi, and of course her areas of interest are all related to fetal medicine. She has been a very active member of the Association of Obs and Gynae in Delhi, the RCOG North Zone, Foxy accredited ultrasound trainer at the current center, and she has many publications in peer-reviewed journals. Dr. Veena Spansal, an eminent gynecologist in Ludhiana who has special interest in high-risk pregnancy, laparoscopic surgeries, and obstetric critical care. She has contributed chapters in Foxy Focus. She has publications related to scar pregnancy, molar pregnancy, placenta previa, IUGR, etc. She has over 100 international and national presentations at zonal, state, and local levels. She has organized several workshops. And Dr. Ashwini Singhal, who is the lead neonatologist currently at Sapling Institute. He has, done his DM neonatology from All India Institute of Medical Sciences and his postgrad DNB in pediatrics, neonatology, MD in pediatrics. And he's also had legal qualifications in medical law and ethics. And his fellowship is from Heinz Visiting Fellowship of the Royal College of Pediatrics and Child Health UK. I welcome all my panelists today, and I'll start off with the first case presentation. What's happening? Sorry. Now, if I could just go on to screen share. Accidentally has opened on my Okay, I've just shut it. So, can you all see my screen now?
Yeah.
Okay, thank you. So the first case is Mrs. D. She's a 30-year-old lady who is in her 4th pregnancy. She has had previous 2 cesarean sections, and the first one was normal delivery. She presented to us at actually 19 weeks, it should say, not 9 weeks, with previous 2 cesareans with a high fetal blood pressure of 150/96. And a scan outside done, which shows an ultrasound reduced growth in twin 2. She is BMI of 29. The first trimester, so it was a in the first trimester history, all history that was available was that it's a spontaneous conception. There were no antenatal visits taken, no lab investigations or ultrasound done, and currently she had no complaints. There was no past significant history. First baby was a normal delivery. Second was a twin pregnancy. She had preeclampsia. So when she had an IUFD of the first twin in the 7th month, then IUFD of the second twin in the 8th month, and she ended up with a cesarean. The third pregnancy was a singleton pregnancy. Again, she had preeclampsia with severe features, delivered by cesarean at 8th month, and this was her present pregnancy. No other past medical or surgical history. Dr. Venus, can I request you, what initial assessment would you have done for this patient had she presented to you in the first trimester?
The most important thing in this case is that this patient has, if from an obstetrician point of view, if I start my in evaluation, she is having a bit higher side of BMI, and she looks like to be, she may be a chronic hypertensive. She is again and again coming up with severe PIH, and there is no in-between history that is available to us. So the investigation related to that hypertension that are needed in between. Moreover, she had severe IUGR, most probably related to that eclampsia, preeclampsia situations, and 2 IUDs related to that. So she needed an APLA syndrome evaluation in these cases, because we need to know the reason for the IUGR and the reason for the early development of the PIH. As she is in this pregnancy showing a high blood pressure at 19 weeks, so most probably she is missing on the chronic hypertension in between. As we are not getting the missing links are there, so we need to take all those history, and definitely the investigations are going to be pertaining to her health first. And then the first trimester evaluation is going to be regarding the twins, as we have given the twin situation in this particular case. So as Dr. Praveen sir has so nicely elaborated, that we are going to look for the ultrasonic findings of the twins. And she needed a CBC, she needs a kidney evaluation, she need a liver test evaluation, she need this urine routine examination, the basic test of the antenatal care that are going to be for everyone, like is the HB electrophoresis and the rubella, and then her blood group. If it is negative, then ICT. And all these tests are going to be a part of the initial assessment, and a good ultrasound in the first trimester if she is going to come. Renal Doppler is going to be an add-on from my side for this case, as this looks to be a chronic hypertension at a young age.
Dr. Bimal, can I just ask you, is there a role of renal Doppler in these patients? Because these are, when patients are presenting to us like this, would you advise having a renal Doppler?
Yeah, because she is a young lady with hypertension, yes, definitely renal Doppler would be. I think probably that would have been done before also, before pregnancy also.
Okay. Thank you, Dr. Venus. Thank you, Dr. Bimal. Dr. Venus, what could you also comment on the gestosis scoring that we should be doing for patients when they're presenting to us with the previous history of severe preeclampsia and otherwise also?
Yeah, the gestation scoring is basically a quite detailed history scoring that is done, and it's a big, all the things put together, and the scoring is calculated. It's not very popular at present in the clinical scenario, and we are not doing it for every case per se. But yes, it is a good score, and you don't miss on the history with the gestation scoring in hand.
Okay. While it's very difficult to summarize in this talk, I think everybody, all the listeners, especially the young obstetricians and gynecologists, should be referring to Gestation score. It should just easily available on the net, and I think that should be done for all patients. Dr. Chanchal, what medications would you have advised given her previous history if she had presented to you in the first trimester? And is there any role of low molecular weight heparin?
It seems that she is chronic hypertensive, and that the question is whether to give them heparin or not. But as Dr. Venus said, that decision should be based on her thrombophilia screening. So if she will need heparin, it will be for as a thromboprophylaxis measure in a woman who's at risk of that, depending on you need the biochemical, you need those investigations to be there. Otherwise, there is no role of low molecular weight heparin in prevention of preeclampsia or prevention of IUGR for that matter. The easiest medicine to probably give is aspirin. Though aspirin, again, in the ASPRI trial, there was a secondary analysis, and they found that aspirin was not as effective in preventing complications of preeclampsia and IUGR in women who were chronic hypertensives. But I think the aspirin is the safest drug to give. So one would, and multiple pregnancy is a risk factor for developing preeclampsia. And with this history, we are likely to land up in it. So I think that would be an appropriate medicine to give.
Right. So for all the listeners, it's important to know that whenever there is a previous history of any hypertension, preeclampsia, gestational hypertension, and chronic hypertension, then the women are at risk at various percentages to develop eclampsia in the pregnancy. And this is just a screenshot of Gestation score, which you can easily get on the net and use as a reference for all your cases. And as Dr. Chanchal has mentioned, that the ASPRI trial has shown us that it does reduce the rate of preeclampsia, but more so in pregnancy-induced hypertension and not in chronic hypertension. Low molecular weight heparin, there was a meta-analysis which was given in the Lancet in 2016, where they analyzed women, 963 eligible women from various care, and low molecular weight heparin did not show to reduce the risk of recurrent placental associated pregnancy complications. So it is not advisable unless and until there is apla-proven thrombophilia, which Dr. Venus has mentioned that this patient should have. And then we should do a two-stage strategy for identification of pregnancies at risk of preeclampsia. The first is, of course, at 11 to 13 weeks, which should be primarily aimed at effective prediction of early onset preeclampsia. Then we should do another one at 30 to 33 weeks, which should be aimed at effective prediction requiring delivery at or after 34 weeks. So further moving on in the case, we did the investigations for her. All her blood tests were within normal limits and she had no proteinuria. In the second trimester, her high BP records at the end of 5th month was she was started on oral antihypertensives. Of course, the NT-NB scan was not done. Dr. Bimal, what first trimester aneuploidy and other screening would you have recommended had this patient come to you in the first trimester?
See, in the first trimester, though we talk about it as an aneuploidy screening scan, but yes, in this case, we would have done the aneuploidy screening with our anti-nasal bone and other markers, then combine it with biochemistry and also with the history, then getting into the preeclampsia screening also, because preeclampsia screening along with biochemical markers in twin pregnancy is also it's quite reliable, and hence we would have gone for that. And at the same time, because we have started with all this, the first thing I would have looked for is the chorionicity.
Certainly.
I would have looked for the chorionicity and then would have done a good first trimester anomaly scan.
Okay. So,
could you hear me?
Yeah, it was very broken. Your link seems to be interrupted. I think, could you please check your connection? We'll just move on further in interest of time, and I'll just come back to you, sir. Level 2 scan showed oligohydramnios, FGR in twin 1. Blood investigations also showed that she had high blood sugars, which was a diagnostic of PGDM. And she was started on the 1800 kilocal diet and advised to monitor her sugars. She was started on Nicardia and labetalol and aspirin and supplements. Dr. Venus, would you please let us know what are the antihypertensives of choice and what are the recommendations based on evidence?
Right, that is actually for the SFM, it is going to be a little more obstetric point of view, but yes, antihypertensive that we choose is most of the time it is the labetalol group first, and we take it to a little, we increase the dose slowly by keeping a watch on her blood pressure, and routine blood pressure monitorings are done. If it is not controlled with one, then we add on the second, and it is usually the Nicardia or nifedipine group that we add on. And if further is added, then many a times it can be a centrally acting or it can be any which is required. But the important thing is that before taking a one drug to the highest level, it is better to add on another at a lower level. So that is how we go with the antihypertensive drugs in the pregnancy.
So, Dr. Chanchal, would you please let us know what follow-up now you would advise for this patient? Because given the scan and the blood pressure findings.
This patient seems to be testing all the high-risk textbook of obstetrics. So she is a gestational diabetic, she is hypertensive, there's a twin pregnancy and one of the twins is growing small. So maternal surveillance would be, as Dr. Venus said, that we'll do a maternal surveillance in terms of optimizing her glycemic control. We would ask her to maintain a blood pressure chart and titrate her antihypertensives accordingly, and do a proteinuria, watch for proteinuria and all the investigations. Now, from fetal point of view, she definitely is a candidate for a 4-weekly ultrasound surveillance. The fact that one of the twin is already showing oligohydramnios, I would not increase the frequency of surveillance before viability, because this is a dichorionic twin pregnancy. So unless she's 24, 26 weeks plus, we would not increase that frequency. So as of now, I will ask her to come back for 4-weekly scans.
I would like to ask Dr. Bimal this question. Would you be able to, would you be looking at chorionicity now in the second trimester that she's come to in 19 weeks?
Yeah, definitely. Because if the chorionicity has not been defined before, whenever you're going to see it for the first time, you need to do it. Even if people have undergone a scan before, majority of the reports I see is just twins. So most of the times we are actually, defining the chorionicity at the time when we are scanning for the first time. So,
and sir, and sir, for our audiences, for our listeners, could you please tell us what is the importance of chorionicity, especially in this case, because there is growth discordance now?
Very, very important in the sense, if it's a monochorionic, see, once we are talking about a selective fetal growth restriction, then the protocols, the surveillance, the management, and everything is going to be different between, in monochorionic versus dichorionic. So the whole structure is going to change. Like if it's a monochorionic, I would be, otherwise also be looking at a 2-weekly scan. Because otherwise also I have to, as the protocol, like Dr. Praveen said in the beginning, you need to do it every 2 weeks. But if it's a dichorionic pregnancy, now that we are at 19 weeks, 4 days, as Dr. Chanchal said, yes, we're not going to hurry and do one more scan in 2 weeks. We'll give it ample time so that we really get to know how the fetuses are growing. And anyway, at 22 weeks, again, if we find something, we're not going to do in a dichorionic. So that's why the chorionicity, see, whenever you get an opportunity, you need to do it. Even if somebody has done it, you're doubtful about it, please recheck it.
Yeah, I think that's the most important thing to remember, how you're going to follow up, because in this case, chorionicity has not been defined. So I sent her to a good radiologist, and he determined that it was a dichorionic twin pregnancy, and then we decided that we'll follow up this patient for every 4 weeks, and we kind of prognosticated her for the smaller twin, that don't expect that it might reach good level of maturity, or there could be a fetal demise also of that twin. Now, we carried on with that. In the next scan, they show that the twin two, the smaller twin, also showed a bulky placenta. Dr. Chanchal, could you please tell us what is the importance of thickness of placenta? And I mean, how do you define that the placenta is thick? When do you say the placenta is thick?
So see, the textbook definition is that any if the placenta is more than 4 centimeter in when measured vertically in its thickest portion, that would qualify as placentalomegaly. As far as relevance is concerned, I think the management here we are this. Especially in this scenario, I think if this is a dichorionic twin pregnancy and there is a growth restriction. In a twin pregnancy, the situation is a little different. However, the main management will be directed by the Dopplers and the growth and the fluid. The presence of placentalomegaly may not alter the management, and the main management is guided by that. Placentalomegaly, you start thinking about hydrops and you want to check the MCA-PSV, you look for infection. It is extremely unlikely that in a twin pregnancy, any fetal infection would affect one fetus selectively. So in this particular case, I'm not sure how valuable or what is the significance in terms of management.
Dr. Venus, would you like to add anything to the relevance of the bulky placenta?
Yeah, I feel that Chanchal ma'am has said it very right, that there is no actually major decision that we are going to take on that basis. It is usually a compensatory change that happens in the placenta, and our decisions are never based on the placental thickness. So seeing a bulky placenta, just going into the whether the lakes are present or not and how much in this particular case, and I don't think even a singleton pregnancy, except for the viral diseases, there is not much significant in many cases that it is hold in clinical scenarios. So in this case, I think we are going to ignore this particular finding for some time and going to focus on the Dopplers.
Yeah, I think certainly in this, sorry, Dr. Bimal, you wanted to add, sir?
Yeah, see, just from the practical point of view, quite a few times what we label as a thick placenta, or it is more of an apparently thick placenta because the short area of attachment of the placenta, because the area of attachment is less, what it becomes more globular, and what you find is a thick placenta. So that is something which you really need to consider before really calling it or really thinking of some other reasons for that.
Yes, even smoking at times is said to be related to this. The history of smoking in the mother is going to be of something because she's hypertensive and carrying everything that that she should not be carrying at this age. So smoking history is going to be important in her.
Okay. So third trimester continued. Now this patient, unfortunately, she had an IUFT of that abnormally growing twin, and the twin one was absolutely fine with normal growth and Dopplers. And at this time, we decided that we should start doing ultrasound with Dopplers every 2 weeks with careful BP monitoring. At this stage, Dr. Venus, could you tell us what extra investigations would you advise for this patient? Now there is IUFT of one twin.
Yeah, immediately after IUFT, there is no extra investigation per se that we advise to these patients. But yes, after the follow-up carries the importance. And, as the time keep on increasing, we keep on monitoring the coagulation profiles of the patient. That is the important thing. And I think Dr. Chanchal might guide that there might be some importance of fetal MRIs in certain cases. She's 29 weeks. But immediately related to IUFT, there is no per se. And in this case, as she is diabetic, any episode of hypoglycemia, HbA1c, these are going to be certain things that can be of some help to us.
Dr. Chanchal, would you like to add anything to that? And what follow-up would you advise for this patient now?
So it's the IUFT occurred in the fetus who had abnormal Dopplers and who was growing small. And I presume that we saw the usual Doppler abnormalities and diastolic flow, absent and diastolic flow, ductless reversal. So we are very sure that the IUD is because of growth restriction in that fetus and not because of uncontrolled glycemic, uncontrolled sugars. Now, thankfully, this is a dichorionic pregnancy. So the risk of due to this demise to the co-twin is very minimal. And if the mother's blood pressure is controlled, and if this fetus, the co-twin, is is growing well and the Dopplers are okay, we would ask the patient to keep a kick count. The risk of DIC in the mother is largely theoretical, as Dr. Venus has mentioned. So maybe we'll document one coagulation profile, but there's no need to keep repeating it. Our aim is the same as before for maternal. For the mother, we want to keep the BP in control, and we want to monitor her sugars. For the fetus, I would be okay with a 3 to 4 weekly scan also if this mother has good control. Maybe the initial scan you may schedule at 2 weeks, but if this fetus is okay, because the aim, even with the co-twin demise in a dichorionic twin, is to carry them on till term, till as close to 37 weeks as possible. So if this fetus is okay, I would be okay to see her at 3 to 4 weekly interval. The frequency of surveillance will depend on maternal blood pressures.
Yeah, we decided to do it at 2 weeks because her blood pressure was very high. Her blood pressure, she was needing increasing doses of antihypertensives. I'm sorry to call you in so late, Dr. Ashwini. Now, this is the time we actually start involving the neonatologists also. What are the risks to the second twin in case of IFB of one twin? Could you please elaborate on that, sir?
Before I go on to that, as a neonatologist, I'm devastated. We were following this mother from 20 weeks onwards. We said we'll do the next follow-up at around 24 weeks. And then we said that the mother had uncontrolled hypertension, and we increased the frequency of surveillance. I believe the parents were offered that yes, from at least 26, if not 24 weeks of pregnancy, the twin which died could have been salvaged in a good neonatal ICU. And perhaps we need to give that option to the parents to decide on that, rather than just expecting that that baby is a growth restricted baby at 28 weeks. I think 28 weeks today is a cutoff for delivering monoclonic twins in a good center. So from that angle, unless the parents chose it or the parents just did not, the mother did not follow for a scan, we accept the IUFT of one twin. Coming to the risks of the second twin, yes, as already said by the panelists, this is a dichorionic pregnancy, not huge risk to the second twin in a dichorionic pregnancy, and we need to continue that pregnancy till term unless there is something which intervenes, maybe a growth restriction and abnormal Dopplers of that twin to really warrant an early delivery. Yes, preterm delivery can occur following the IUFD of one twin, and the risk is somewhere around 50 to 60% within 2 to 3 weeks. So if we know when that happened, 50% of the times mother might end up in labor. So once that happens, we need to deliver her. As far as counseling the parents, now once the twin has died, we say that yes, the other twin is doing fine, and the Dopplers are fine, the growth is fine. So we continue the pregnancy, but impress upon them the need for a stringent follow-up, and as and when we discover any abnormalities, we counsel again if the babies need to be delivered preterm.
Okay. So Dr. Chanchal and Dr. Ashwini, I pose this question to both of you. There are many a times the situation comes when we are worried about one twin, and one twin is growth restricted, there are abnormal Dopplers, and there are even absent end-diastolic flow. And now the situation is that they're around 27 weeks, let's say. So would you now deliver the patient at this stage, and or would you wait and just prognosticate? I think, you know, how from the legal point of view, Dr. Ashwini, sir, because you have legal qualifications as well, could you please also, both of you, one by one, tell us what would be the important things?
So let me talk about the antenatal part, and Dr. Ashwini can add on to the postnatal part. See, in a twin pregnancy, in a monochorionic twin pregnancy, the decision is very straightforward. Deliver them once they are viable before there is an IUFT. In dichorionic twins, because we're in a very unique situation where the appropriately growing co-twin is at risk of iatrogenic prematurity, the two main factors which decide whether you would deliver them is the gestational age. If we are in a center where 27 weekers can be saved, we would, if we reach pre-terminal Dopplers, then I would explain the risk of prematurity to the co-twin. But in the interest of the saving the smaller going twin, we can offer delivery. We should discuss. It's a matter of discussion. There are no legal implications here because here we are caught in a situation where there is no strict way of saying this is right. And it would also be determined by the weight of the baby. If you were 400 grammer at 27 weeks, and there is no genetic testing available, you do not have the time to do a microarray. It could be a genetically abnormal baby. So every situation has to be individualized. So if the baby is of a weight where your neonatologist is comfortable, at a gestational age where the nursery is comfortable, then we talk about saving both babies. The second important thing is that the Dopplers, the monitoring of these twin pregnancies, dichorionic twins, the delivery has to be done when the ductus gets reversed or abnormal, not when the umbilical artery is absent or reversed. So we follow the truffle protocol in these dichorionic twins. Even 2 days, even a single day gain in utero before 32 weeks will improve the survival by as much as 2 to 3%. So the timing of delivery should be guided by the ductus venosus Dopplers before 32 weeks.
Okay. And Ashwini sir, any inputs? Yeah.
I think we've been changing the cutoffs over the last few decades from 34 to 32. I would not be very happy with an absent end-diastolic flow at 30 weeks and wait for the ductus venosus to get abnormal. I think 30 weeks, a baby who's 700, 800 grams, the smaller of the twins, it is offering to the patient your own data, the comfort level of the neonatal ICU in handling these small babies. But a 30-weeker, 700 to 800 grams, I would be happy delivering, then wait for the ductus venosus to become abnormal, and then have a sicker fetus delivering and taking care of that baby in a neonatal ICU. If I had got a chance, we would have presented this from a neonatologist perspective. We've gone through this. Babies 700 grams, one of the twins, and these are dichorionic because one was a boy and a girl, and the other a normal growing fetus. We had delivered at 30 weeks. The fate was such that the smaller baby did much better than the bigger baby, and the bigger baby had a PDA, went on to require oxygen for long periods. So once you're comfortable having a baby at the gestation and the weight that is there, I would not wait for a ductus venosus to become abnormal till 32 weeks. Maybe 28 weeks, yes. Not 28 to 32 weeks, we carry on a baby with reverse end-diastolic flow, waiting for the ductus abnormalities to occur. That would be a difference of opinion with Dr. Chancel. But then again, that needs to be talked to the parents. The delivery has to occur in a center where babies can be cared for, and that is it.
Our protocols also say that at 30 weeks with reversal of diastolic flow, definitely yes, that is an indication. At 32 weeks, even with absent diastolic flow, we will deliver. So these protocols are quite clear about it. But before 30 weeks, yes, we use ductus venosus as the cornerstone.
Absolutely.
There is one more,
there is a lot of so the reason why these cutoffs came, it was, see, the question is not having a live child at birth. The question is to have a neurologically intact child at 2 years of age, and the truffle was about this question. So absent end-diastolic flow 32 to 34 weeks, a reversal 30 to 32 weeks. However, the women who are hypertensive, we will rarely wait for so long. We hardly get more than 5 to 7 days. But if in preeclamptic women, the deterioration is much faster, and most of the times the delivery is needed for a maternal indication. So the consensus is that you may be converting by an early delivery. If you don't wait for long enough, you just might be converting a stillbirth into an early neonatal death. So that was the truffle. That was the trial. The primary outcome of the trial was neurodevelopmental outcome at 2 years of age. So that's where
at 27 weeks with one.
I don't have my this thing.
The other baby growing well and then delivering. I think, of course, as Dr. Ashwini said, this should be the parents, but decision eventually would be theirs.
Almost खत्म मतलब खत्म हो गया कि होने?
Yeah, Naveen, can you mute yourself? Yeah. So that decision would be the parents' decision whether they would really, for the smaller one, they would like to have the other one also that premature. Yes, as Dr. Chanchal said, survival, yes, 27 weeks, 26 weeks, good ionized use, but long-term, long-term sequelae could be still not as good with a 30 weeker than with a 26, 27 weeker.
There is one more thing that I would like to add, the very nicely put on by my co-panelist, is that there is a very significant history in this patient that she had one IUD at 7 months in previous pregnancy and another IUD at 8 months in the previous pregnancy, and that too landed up in a cesarean. So I feel there is some amount of individualization of case and a very thorough audiovisual counseling with the family, giving them all facts and figures, giving your own data, giving the international data, giving the Indian data is going to be very, very helpful. And a bit of individualization in certain cases is, I feel, is not a bad idea. She has a very bad history earlier.
Absolutely, Dr. Venus. It's all about individualization.
Yeah.
I agree.
Bimal sir, I think Dr. Zini has some problem logging in. She's just had some internet connection issues. If you could start taking over the questions, maybe till that time she starts logging back.
In fact, yeah, okay, we have one here, which, should the patient be informed about the limitations of a Gestation score? It has a low detection rate. Yeah, Dr. Venus.
Yeah, we have already done with that. Just to, okay, you are taking it from the chat. So Gestation score has a very low detection rate, but yes, I see if it is done for all the cases, we usually don't miss on any history. And when we don't miss on any history and examination, we are in a better condition to handle that case for the further antenatal care. So it should be done in the cases. However, many a times it may not be able to give you a clear-cut management protocol for that patient.
Praveen sir, though you have already answered in the chat box, but for everyone, it is an important question. Like in the first trimester, you have a CRL discordancy between the two embryos, which if you have to assign the gestational age, will you use the smaller or the larger?
Larger CRL. Larger CRL. And if it is more than 14 weeks, we take the HC, larger HC.
Sir, is the number of yolk sac always reliable for amnioticity, or there is still some confusion with that?
No, there is a lot of confusion in the sense. See, the concept of yolk sacs being used to ascertain the amnioticity is basically because less than 8, or even less than 10 weeks to identify the amnion is difficult, even by transvaginal route also. So that is the reason why they have started using yolk sacs as a factor which will ascertain the amnionicity. But then ultimately, when you really want to decide the amnionicity, it has to be that you need to demonstrate the intertwin membrane. Without demonstrating the intertwin membrane, just based on the yolk sacs alone, you would not like to ascertain it.
You can have a diamniotic with a single yolk sac also.
Yes.
But very, very rare, right?
Rare.
Very rare. Okay.
Sir, I have a question, Kilan sir, if for the benefit of our audience, if you could just elaborate why you would want to take the larger CRL for larger fetus for dating with a larger CRL. What's the reason for that?
The reason is very simple. See, when you are assigning the gestation age, whenever there is a discrepancy of the CRL, usually the discrepancy also may be associated with certain aneuploidies or particularly the triploidy. So that is the reason why we try to avoid the lower one. And not only that, when you are ascertaining a gestation age, it is always better to use the larger one rather than the smaller one. So these are the factors which decide that it is the largest CRL that we need to consider as far as assigning the gestation age is concerned based on CRL.
And another reason is it is better to over-suspect fetal growth restriction in twin pregnancy than to under suspected,
Rightly
Once
said.
you assign it by the larger one,
Yeah.
that
In later gestation, you might think that this baby is growing appropriately because you dated by the smaller CRL, whereas that fetus might actually be growth restricted. So not to miss out inadvertently in growth restriction.
So, Praveen sir, a follow-up to your answer is, so should we not talk about, should we not mention the amnionicity till we see the amnions? Or just based on yolk sac, you can still label it as...
No, that is for your, see, basically we have to be very clear. See, the most important thing is the chorionicity rather than the amnionicity. It is the chorionicity which is going to create a lot of problems in our evaluating the multiple gestations as well as management of these things. But the amnionicity is basically very important because when you want to differentiate between a MCDA and a MOMO, it is essential that you need to demonstrate the intertwin membrane. So that is the reason why you need to. But then basically, initially when you start off, when you don't have the amnion which is being demonstrated 10 weeks or 8 weeks of gestation, a rough idea is taken based on the yolk sacs. That's all. Not beyond that.
Yeah. I think Dr. Zini is logged in back. Over to you,
Sorry,
Dr.
I don't know what happened with my connection. It's the bad weather. I think it's very windy outside. So nothing, Dr. Ashwini, sir, as you said, what had happened in the case that I was presenting. This patient she was a very poor compliant. Till 19 weeks, she had never had any antenatal checkup. Then she had a scan at 22 weeks. We were calling her every 4 weeks. She came at 29 weeks with an IMFT. So I completely agree with you. I think you are absolutely right in saying that we need to give them a choice. We tell them what is the outcome. So ultimately, then we carried on. There was, and the points that I wanted to highlight was, do not be scared. If one twin has died, carry on these pregnancies till term and then deliver them. Then, yeah. Do you want me to share my screen again? Okay.
No, if you want to, otherwise.
Yeah, I'll just summarize here.
Yeah, okay.
So what had happened was, so this is, right. So we were here. So this patient we had lost her to follow up, and then that's then finally when she came, her blood pressure was very high, it kept on increasing. So this is what had happened. She had come to us at the 29 weeks with the absent, fetal heart in one twin, and we kept on monitoring her. The reason why we increased the frequency of scans for this patient was that and now the second twin started showing reduced and end diastolic flow with higher PI values. And even then, we were only following her every week with the Dopplers. And finally, at 33 weeks, we decided to deliver her because she has, she had very high blood pressure. So my question is, of course, what is the ideal time, which I've already said 37 weeks. And Dr. Ashwini, could you please tell, for the benefit of the listeners, the role of magnesium sulfate and steroids for the baby when you're delivering them preterm?
Obviously, I believe we've gone past this era where we would deliver any baby without steroid coverage. Even if you have 2 hours to deliver a baby, it is recommended, give the steroids to the mom. We don't know, we might end up with 6 hours, 12 hours, and we know that 12 hours is good enough to have some impact. So antenatal steroids have been associated with decreased risk of fetal of neonatal death, which is almost 50%, decreased risk of respiratory distress syndrome, decreased risk of necrotizing enterocolitis, decreased risk of IVH. So we not only talk of increasing survivals, but decreasing morbidities and decreasing long-term adverse neurodevelopmental outcome. So none of the babies who are delivering less than 34 weeks completed, or let me say less than 35 weeks completed, should deliver before being steroided, the mothers. Beyond 35 weeks and above would be perhaps a matter of debate, but not less than 34 weeks. Similarly, magnesium sulfate, I think most people would be happy giving less than 33 weeks. All mothers who are imminently going to deliver within the next 24 hours. So you could either of the regimes, but the most common being 4 gram IV stat followed by 1 gram per hour till the mother delivers. And if the mother remains undelivered at the end of 24 hours, we stop it, and then we can restart if the mother goes into labor again or planned to deliver again. Magnesium sulfate associated with decreased risk of cerebral palsy and decreased risk of adverse neurodevelopmental outcomes. So again, it should be the norm. I think steroids have caught up. Most of the people are following the guidelines, but magnesium sulfate, for some reason or the other, is not so commonly administered. But realize that people are more worried about the magnesium that was being used in eclampsia and associated abnormalities in the mother in terms of renal failure. But those are more related to the eclampsia that is happening, and a single dose of 4 grams is not going to cause any harm to the mother in most situations, and that needs to be given. Just put it in 100 ml of saline and administer over half an hour, 4 grams, even if you're taking the mother up for emergency cesarean into the OT. That would go before the mother is delivered.
So just to summarize, what I would say, counseling and support is extremely important. You should have individualized management plan if you have a situation like this. It has to be, the management of these patients has to be at a tertiary center with competent neonatal support. It is of utmost importance that we have information on chorionicity. We should look for fetal anomalies, and we should have close fetal surveillance as guided by the chorionicity. Steroid prophylaxis, of course, less than 35 weeks or sometimes even 34 weeks in case you're expecting a preterm delivery. If their other twin is growing fine, then go with the conservative management till 37 weeks. Although vaginal delivery can be done in these patients, but in literature also, most of these patients have ended up with a cesarean section, because obviously the parents are very worried now also. Earlier intervention in the presence of other obstetric indications. Postmortem examination wherever possible is extremely important, but if you don't have that, then at least send the placenta for histological examination, and of course pediatric assessment and long-term follow-up. I don't think we have time for the second case, but thank you, my panelists. You've been great, and it's been a great learning experience with all of you, and hope we can do the second case sometime. And we thank you all. I would request Dr. Bimal to continue with the audience interaction with the questions in the chat box as well. Thank you, sir.
Okay. I think most of the questions have been already answered here. And
Sir, I would want to ask one question regarding the issue of vanishing twin. If anyone in the panelists or Dr. Kilian sir could just tell me, in the case of vanishing twin, when would we want to do a biochemistry analysis?
you have to
if and when
you have to give a minimum of 4 to 6 weeks.
6 weeks.
Yeah, 6 weeks there, and that is why if you have a vanishing twin, it is better that you do the screening with just the maternal age and NT.
Right.
Rather than including biochemistry there, and Praveen sir in his lecture has shown that there is not really much of a difference when you add biochemistry in twin pregnancy, as compared to just maternal age and NT. So that is quite good enough. Yes, the false positive rate comes down, but
yeah,
otherwise the sensitivity detection rate is quite good.
Great, thank you.
Yeah, that's an important aspect. That is why it is important that we should know that there has been a vanishing twin.
Yeah.
The dictum is if you can see a fetal pole at your nipple scan, don't do the biochemistry.
Yeah. But why put through this is some thank you everyone for an excellent discussion. Once feticide has, I think there is an issue with which is going on with the first case, that why the genetic testing was done in a case of anencephaly. Yeah. Yes. So Rajiv has already been answering and discussing on the chat box. Dr. Chanchal, anyone would like to, because anencephaly can be associated with genetic syndromes.
So, sir, I mean, if you look at the literature, the maximum data for fetal reduction comes from the New York University, the Mark Evans group. it is their protocol, even in normal, morphologically normal, with no markers of aneuploidy. They do offer a CVS prior to any reduction to all patients, and the over and above pickup rate from conventional screening, screen negative, the number that they have given is 1 to 1.8%, which is not less. So I think just because we are planning a reduction does not mean that the counseling changes. You should offer invasive testing. I mean, it's just an additional 0.1% risk of miscarriage. So I think that we should not get caught up with why to do an unnecessary invasive. If a patient, if you counsel them and if they want more than 90% information, they get it. They should be offered.
Yeah, and not only that, see, when you are doing a reduction, I think it's always better to offer them the possibility of evaluating the because you need to be sure. Tomorrow you reduce this, and then again that becomes abnormal, and then you feel bad. So that is the reason why it is better to offer. If the patient refuses, that's a different story. But if they agree, I think it's your responsibility to do it.
So you always discuss that. I mean,
I have
Sir, can I interrupt just one? I think Dr. Ashwini was wanted to ask कि अगर expected management है, if there is expected management, then can we do this genetic testing?
Expected management. See, you mean to say that you just leave it like that?
Yeah.
Just leave it like that. I mean, see, even then also it is essential that you need to establish the other fetus is normal, isn't it?
Definitely.
See, when you are reducing, when you are doing it, it's when you are leaving it also, it is the same.
Another reason why this genetic testing really helps is even when you want to take a decision of expectant management versus selective reduction. Even if, suppose if it's a monochorionic, if you want to take that decision, the abnormalities, and suppose like it turns out to be trisomy 18, this is lethal, I would probably not do anything. But if it turns out to be trisomy 21, I would offer selective reduction there. So if it is a lethal abnormality, but yeah, if in cases of like trisomy 18, we know is going to be lethal, we can just say, okay, no problem, let this remain. If it's a monochorionic, why unnecessarily put the patient through the risk of all this? But in cases of anencephaly, again, anencephaly is so, but then there are certain anomalies which are lethal, but they can cause a lot of problem to the other fetus, like anencephaly, where the polyhydramnios can cause prematurity. So all these things need to be balanced, and in such situations, yes, the genetic testing does help. It does help.
Not only that, the point is this. See, basically, even suppose you are doing just a selective fetal reduction, the fetal reduction, multi-embryo reduction. Even then also we do offer them saying that it is better to evaluate the other two embryos which you are leaving, whether they are normal or not. It's only a counseling, pre-test counseling that you do. But when you have an abnormal fetus where you are going to do a selective termination, it's much more your responsibility to offer them the possibility of a invasive testing in order to confirm whether the other fetus is normal or abnormal. I think you cannot ignore that.
Okay. Thank you so much, everyone. Thank you, Dr. Bimal. Thank you, Dr. TLN, Dr. Chanchal, Dr. Venus, Dr. Ashwini, Dr. Rajiv, Dr. Kavita, and of course, Dr. who am I forgetting? Nobody. Dr. Naveen, I now call upon you to please give your vote of thanks and wind up this session for tonight.
Yeah, I think you have done a wonderful job, and I would really thank everyone for staying up so late. Talen sir, thank you so much for sharing your knowledge and your wonderful lecture, sir. And Dr. Bimal sir, for your knowledge you have shared, Dr. Chanchal ma'am. And I would also want to congratulate Dr. Rajiv and Dr. Kavita for the regular participation, their case presentations, and very nice. And I would like to also invite other members of Ludhiana SFM to share their cases and case presentations. This was part 1 of challenging situations in twins, and the next part, I would be wanting others also to take a part in that. Also, our local faculty, Dr. Venus, very good job, ma'am, and Dr. Ashwini with your perspective of the neonatology aspect. And finally, also, Dr. Zini, you have done a great job, wonderful job, and we are very proud of you. You have done a great job as a moderator and convener with your logic-based and evidence-based approach, which you always do. Great job. And finally, the audience, for a very patient hearing, for staying on till so late. It's almost 10 p.m. And we end on that note with that one very important thing that Dr. TLN has stressed on, and that whenever we do an ultrasound, we always need to mention curiosity, because that is so very important. We really cannot overstress that. Thank you everyone so much.
There are no twins in ultrasound. They are either monochorionic or dichorionic.
Yeah,
True that.
Definitely.
You can't
There's-
make any decisions otherwise as an obstetrician. So
Because-
when this lady came to me at 19 weeks, I didn't know what to do. I said, first tell me the curiosity. I have no idea what to do now.
Yeah.
Okay. Thank you so much, everyone.
Thank you so
Thank
much.
you, everyone.
Thank you,
It was
everyone.
very
Thank you,
informative.
everyone.
We
Thank
need
you.
to thank Vishal as well as the Conferences International.
Of
Definitely.
course.
Vishal
Thank
has
you,
the great
Vishal.
technology.
Thank you, Vishal. Thank you so much.
Thank
Every
you.
time.
Thank you.
Bye. Good
Yeah,
night.
he keeps pushing you to make sure things are on, deadline is
He
met.
keeps pushing us. Yeah. Yeah. Thank you
Great
so much, Vishal.
coordinator.
Bye-bye.
Bye. Bye.
Bye-bye.
Good night.
Good night. Good night.
Good night. Good night.